The last one is now a presentation, a video clip from Abigail Hatcher. Abigail is a senior researcher at Wits, Reproductive Health and HIV Institute. She wasn't able to make it, but she graciously sent us a video clip. So I would like to request that we run the video clip and then we go into the questions and comments.
Good afternoon, and thanks for allowing our team to join you today from afar. We'll be speaking about linking IPV screening to ongoing referrals by building referral networks. Recent research has shown that IPV in pregnancy and during the 12 months leading up to delivery is considerably higher in sub-Saharan Africa than in other regions globally. So today we'll be focusing on IPV in pregnancy in Kenya and South Africa. We know that IPV in pregnancy has deleterious health effects for the woman. These include pregnancy-related outcomes, but also mental health and healthcare uptake. And importantly, when a mother experiences intimate partner violence, it has large health effects on the child. So recent research has shown that mortality increases all the way from fetal loss all the way up to neonatal death and under 5 mortality. But screening for violence during routine antenatal care is a crucial opportunity for the health sector to help reduce IPV in pregnancy. And research has suggested that screening in antenatal care may offer an important window of opportunity during a time when women are already accessing health services in a routine manner. But for IPV screening to work effectively, it needs to be connected to referrals. We know from work that Patricia Ocampo and her team did that referrals are a crucial aspect of ensuring that healthcare providers are able to effectively screen for intimate partner violence. And similarly, referrals are important for the clients themselves. When women are able to access referrals that are useful and responsive, they may be more likely to move along the pathway of change towards improved mental health and potentially towards a reduction in the experience of IPV. And so even though the East African setting, and indeed the Sub-Saharan African setting, has high rates of IPV in pregnancy, there have been very few research examples of programs that help to address IPV in the health sector. So today we'll talk a little bit about our team's work in rural Nyanza province, Kenya, as well as urban Johannesburg in South Africa. Along with KEMRI, UCSF, and University of Alabama in Birmingham, our team has been researching gender-based violence in rural Kenya. And we started off by looking at formative qualitative research that suggested local resources do exist to address violence, but that very few women or health workers were aware of these services. And similar to what's been found in other settings, pregnant women were reluctant to use referrals if it meant bringing their own husband to formal justice through the police system. This is often not an option for women in this setting. And so with guidance from our formative qualitative research, our team developed an intervention that was comprised of 4 stages. First, we built local partners. Then we trained the health clinic. We tried rolling out antenatal IPV screening, and then we refined and assessed the approach. For today's presentation, I'll focus on the first step, the work with local partners. And so we used materials from Raising Voices in Uganda to help our local partners name the violence. We also did participatory activities such as mapping resources in the community and figuring out the strengths of the local providers. And our last step was to work with these providers to build a comprehensive referral network. So one of the most innovative ideas that came out of this local partners meeting was the notion of finding lay health workers who could serve as community referral persons. These local partners helped us realize that women would probably need some assistance in accessing onward referrals. So community referral persons were lay health workers who volunteered to either refer women from the neighborhood to the health clinic or to escort women from the health clinic to other existing referrals in the community, such as a pro bono lawyer who specialized in IPV, or the police station who could help with medical legal cases in a situation of rape. By the end of the 2-day meeting, the group had come up with quite a comprehensive referral tree, which encompassed local government, the clinic, these new community referral persons, as well as other local IPV services. And the referral tree included names and cell phone numbers of each person on each aspect of the tree. After designing the intervention in collaboration with the local partners and the clinic, our team was able to briefly assess the intervention, and in total, 134 women were screened for IPV in the antenatal clinic. The pilot ended up going so well that the staff of the clinic took the initiative to scale up IPV screening and supported referrals to other areas of the clinic. And as you can see in the pie chart at the bottom, 37% of women who were screened were categorized as experiencing or at risk of experiencing IPV. Of these, many were successfully referred to the community referral persons who helped them take the onward step to access referrals such as police, the local administration, or other assistance. One challenge of the intervention was that the screening seemed to drop off over time, so it suggested that we needed to refresh the clinic so that they were able to retain rates of screening. But overall, the intervention seems promising in a rural setting, and we believe with some improvements it could be scaled up more widely to primary health and antenatal clinics in the East African region. So to change gears just a little bit, a similar intervention is being developed and tested in urban South Africa. For this work, the formative qualitative research suggested that women are often unaware of some of the more helpful referral services, such as social work, counselors, and NGOs. They do seem to be aware of some informal help, such as family, friends, and church, but these are perceived as sort of less useful to the women. So part of what we wanted to do was to establish a referral network that would be more helpful for the women themselves. And we took an iterative approach to building this referral network. It took quite a bit of time to have initial formative research meetings with local referrals, and also to ask those services if they had the capacity to take on additional clients from our project. We had a formal launch of our intervention, which is called Safe and Sound, and then we've been engaging in ongoing relationship building with these referral services. Our team developed training materials around establishing the referral network, but then also around using it with patients. And we've developed an intervention manual that should be available in about 4 to 6 months, which we'd be happy to share with this group. The idea around the safe and sound intervention is that it should be then testable among a group of 600 women who are experiencing intimate partner violence in pregnancy. And so along with the World Health Organization, our team at University of Witwatersrand is testing this in a small randomized control trial. And we anticipate that we would have preliminary findings by the end of 2015 and hopefully have a better sense for whether this intervention can impact on the mental health, safety behaviors, and intimate partner violence experience of pregnant and postpartum women. So in summary, we found that in both rural and urban settings, it can be very useful to use a referral network approach to linking women from IPV screening to ongoing care. In rural Kenya, the clinic was certainly a key resource in the community, and we found that liaising with the local government and other informal service providers was a useful way of accessing ongoing referrals. We also found that lay health workers can serve as referral persons to help link women from the health clinic to onward referrals. In urban South Africa, the clinic was similarly seen as a trusted entry point for women. We learned that women often don't know about existing IPV services, and so even though these referrals may exist, it's important for us to help clients become more aware of those services, and also for our team to assess the capacity of those referrals to take on additional clients. So similar to other settings, we've been learning that the health sector does play an important role in allowing women to access onward referrals for IPV services. But we'd really encourage other teams to recognize that just providing the names of referral organizations is generally not enough. Women do require additional enhanced referrals in the form of reimbursement for transport, or being escorted to the next service, or at least a cell phone link between the health sector and the IPV referral. These type of referral networks do require reinvigoration, and that takes a lot of time and effort. With additional development and testing, this kind of referral network approach may be crucial to ensure that the health sector can intervene and address cases of IPV. We want to thank the women and health workers who have generously given of their time to help this research, and also thank our funders and our partners in both the Kenyan and South African Ministries of Health who have ensured that this work gets tested and developed in order to help women experiencing IPV in pregnancy.
Abigail is not here, but I'm sure that she will telepathically hear our clapping, so we can clap the second time. So again, we'll thank Abigail for responding to one of the objectives of this particular session in highlighting promising approaches to integrating IPV and HIV prevention and care by specifically looking at these referral networks. And I think her message is resonating very well with the previous presenters, that it's not just a matter of providing those referral networks, but that you have to there has to be enhancement of the information and really walking through the IPV exposed persons in this process. And I think it's also very interesting that we are seeing a case of, of a study that is taking not only rural-urban, but also cross-country comparisons. And we really want to move forward in that so that we can increase on the generalizability and if we're scaling up and if we're going to Gates, who doesn't fund small scaling up programs, then we say we're doing in Kenya, Tanzania, South Africa. And again, the network of the African academies, I think, should come in handy in bringing together all these various interventions that are out there.